Hello, professionals. This is Dr. Saad, and as you know, we are recording series of lectures for pharmacists who are going to appear for international equivalency exam. So let's resume our topic as we were discussing about some anxiety. We will finish this topic today. Let's Today our first point of discussion, that is remaining part of previous lecture, is about the metabolites of benzodiazepine drugs. As you know that benzodiazepine drugs, there are some examples like diazepam, chlordiazepoxide, and chlordiazepate, and prazepam. These four drugs, they are metabolized. They are metabolized in liver through oxidation, and their metabolites is desmethyl diazepam. And this step, if person is suffering from liver cirrhosis or elder patient, this step is impaired in them. So there is a chances of the deposition of or accumulation of these drugs, and their sedative action will increase. That's why, as I told you in the previous video, put a point of lorazepam, as it is one of the most effective drug for nighttime sedation with or without liver cirrhosis. So we will move for that option rather than using the diazepam, whose dose is 5 mg BD, and chlordiazepoxide, whose dose is 10 to 20 mg TDS or BD, or chlordiazepate, whose dose is from 5 to 7 mg BD. Next, point number 24 of remaining part is that about the same metabolites of flurazepam. As you know, the flurazepam has very long half-life, and it causes after morning effect because of its very long half-life, and similar to previous drug. It also metabolizes in liver through oxidation, and its metabolite is desalkyl flurazepam. So after morning effect is a one of the problem in its implication. So let's move on toward the next point, that is about the dose-related hypnotic effect. Keep in mind that all benzodiazepine has dose-related hypnotic effect, but FDA approved four out of them, that is the flurazepam, lorazepam, temazepam, and triazolam. These four drugs are being approved by FDA for you can manipulate them to get a dose-related hypnotic effects. As you know that lorazepam, its dose is 1 to 2 mg OD or BD. Temazepam, its dose is from 7.5 mg to 30 mg OD. It has a rapid action because and its half life is about 10 to 15 hours, so it don't have any after morning effect. So instead of using lorazepam, we can choose these drugs. This was all about our remaining part, and next point is about the midazolam. It is used as for the anesthesia purposes. And for there is the next point, point number 27 is about the bipolar disorder. As you know that bipolar disorder, in there is a two stage at the same time. Sometimes patient feel mania, manic stage, in which patient feel a very excited, hyperactive, and there's no need of sleep. On the other hand, there's a depressive stage. Both stage turns around and comes side by side. So it is recommended that why we shouldn't use benzodiazepine in bipolar disorder because of it increase the GABA receptor, and GABA will may push patient from will depress the patient, and patient we may push a patient from manic to depressive state. So managing the bipolar disorder is a very technical issue, so we avoid benzodiazepine implication in case of bipolar depression. Point number 28 is about the overdose of benzodiazepine. For example, if patient got excessive dose of accidentally get exposed to overdose of benzodiazepine, then we have to use benzodiazepine antagonist. Its name is flumazenil. We will use as an to manage this overdose of the benzodiazepine. So this was all about the anxiety and its related effect, and we actually discussed the gamma aminobutyric acid neurotransmitter and its role for the managing of anxiety and sleep disorder and anesthesia. And now we will move on toward our next point, that is about the depression. Before going into the technical detail, just for review, as you know, the depression is a if patient is depressive, you will feel he has loss of interest in any activity, like he has no interest, he has lost its interest in player and any social activity. There is a associated condition like coronary artery disease, and diabetes and stroke. If a patient stay in a very long term in a depression, then these associated condition can be one of the risk factor for such type of patient. And so we need to manage the patient who are in depression. There are many types of depression like panic disorder, generalized anxiety disorder, post-traumatic stress disorder, obsessive compulsive disorder, postmenopausal depression, and MDD. These are the major depressive disorders, like MDD is called as. These are the various kinds of depression, and it has very specific pathophysiology. Just keep one thing in your mind, that whenever serotonin or norepinephrine, or you can say catecholamine level drops, patient will go in the depression. This is the single point approach, that we have to maintain serotonin and norepinephrine catecholamine level high to bring patient out from the depression. This is our all therapeutic approach. So for that, we must need to go and revise the synapse and presynaptic membrane and postsynaptic membrane, anatomy and physiology of central nervous system neurotransmitters and neurons. They, as you understand about, as you know about these these neuroterminals and ganglia of peripheral nervous system. So it is almost similar to that, but there is a little difference of neurotransmitter and receptors. Like in as I told you earlier, that we have to improve our serotonin and norepinephrine or catecholamine level. So for that, we will use various approaches. As you know, there is a mono enzyme called monoamine oxidase enzyme. It actually metabolize the serotonin as well as norepinephrine, which is produced by the tyramine and 5-hydroxytryptan. So it actually metabolizes them and convert and shift them into inactive form. This is a step which we control and block this step through the use of monoamine oxidase inhibitor, and it will, through this way, our presynaptic vesicle would have a higher amount of catecholamine and serotonin level. Similarly, once serotonin level released, we will use we will try to avoid its reabsorption back into the synapse. So in this way, active amount of catecholamine and serotonin will be available in the synaptic cleft. That's why patient will get out of depressive symptoms. So for that, we will use specifically two classes, that is the selective serotonin reuptake inhibitor, which actually block the transporters, and second is the selective serotonin norepinephrine reuptake inhibitor, which is known as SNRI. We will use in this through by the use of this drug, we block both norepinephrinic reabsorption as well as epinephrinic as well as serotonergic reabsorption. Similarly, there is also receptor known as 5-HT1 receptors and T2 receptors. There are several types of receptors which facilitate in the reabsorption of serotonin and norepinephrine back to the presynaptic presynaptic membrane. So these receptor modulator like 5-HT3 modulators are also used for its management. Similarly, fourth type of class which or mechanism which we use is the tricyclic antidepressants. These are the depressants which also play the same role, increase the production of increase the level of catecholamine and serotonin in the synapse. But all these drugs like SSRI, SNRI, tricyclic antidepressants, 5-HT3 modulators, although they increase the catecholamine level as serotonergic level high, but at the same time it produce one problem, that is it also blocks the muscarinic receptor, alpha receptors, histaminergic receptors, and these are side by side the blocking or side by side their pharmacological effect. So where we get a patient out of from the depression, at the same time there is high chances of interaction with the if a patient is using concomitantly, we are treating patient with concomitantly the muscarinic or alpha or adrenergic or histaminergic medications, then there is a huge chances of interaction and side effect relevant to that. We will discuss everything in relation in upcoming points and in coming videos. So this was the introduction of our depression and its types and its mode of action and our strategy to manage this. So point number 2, which I want to discuss in depression topic, is the about the MAO. As you know that, as I told you, when you will block the MAO, norepinephrine level will increase. Another word In other word, if on the other side, if a patient is eating something like anything which contain food tyramine, like cheese cheese, like things like any food beverages like which contain high amount of tyramine, then there is no MA available to control the level of norepinephrine. Then over at a very high level of tyramine. Sorry for interruption. As I was telling you about the tyramine containing food, so as I told you that when patient already using MAO inhibitor and there is a high level of you is also consuming side by side a high level of tyramine food, so there is a chances of hypertensive emergency and symptom like excessive amount of adrenergic transmission or excessive amount of related sympathetic activation related symptoms will be visible in patients. So it can be a situation of emergency. One of them is hypertensive crisis. So we should control the patient from using such kind of tyramine containing foods once he is an MAO user. So point number three is about the tricyclic antidepressants. As I told you that tricyclic antidepressant will only be used when SSRI or SNRI is unresponsive. When we can't get a response from SSRI or SNRI drugs, then we will shift toward the tricyclic antidepressants. Point number four is about trazodone. Trazodone is a H5HT receptor modulator, as I told you mechanism, and its dose is 150 to 300 mg per day. The point which I want to tell you that it has no any muscarinic effect. So if it is mandatory to modulate without getting a muscarinic effect, then trazodone is one of the nice option. So trazodone don't have any muscarinic effect. Point number five is about the phenylcypromine. It's a MAO inhibitor antidepressants, and its dose is about 30 to 60 mg per day. Similarly, point number six is about the theophylline dose. That is theophylline. It actually decreases the level of lithium in the body. Point number eight is about the onset of TCA, tricyclic antidepressant. It requires about 3 to 4 weeks. As I told you that when you in the mechanism, one thing I forget to tell you there, once you increase the level of norepinephrine and serotonin, it's due to activation of autoreceptor, the onset of antidepressive action will be delayed. It will appear after 3 to 4 weeks. And specifically in case of tricyclic antidepressants, patient would get out from the depression after the administration of medication after 3 to 4 weeks. Point number nine is about the TCA. As I told you previously, the interaction, we will talk about two interactions. Like one interaction is with the ganathirdine. This is the antihypertensive drugs. Once a patient is using TCA, and its example is imipramine, and amitriptyline, both have the same dose. Its about dose is about from 150 to 300 mg per day. Similar doses for amitriptyline from 150 to 300 mg per day. If patient is already at TCAs, and we should avoid this guanethidine for the management of hypertension in such patients, because as you know that TCA blocks alpha blocker, so TCA blocks the alpha receptor, so here is an interaction with these drugs. So we should shift this patient toward an alternative antihypertensive drugs. Similarly, in case of glaucoma, as I told you that TCA cause antimuscarinic effect, and if your patient is glaucoma and he is using antimuscarinic drugs, he's using a muscarinic agonist. So with the concomitant use of tricyclic antidepressant, patient will these TCAs should put an antagonist action at the muscarinic receptor in eye. So will shift from patient people will shift from meiosis to mydrotic state. Then there will be this is a contraindication if you use TCAs side by side the and you can say muscarinic agonist. So we should avoid this combination. Similar cases for the histamine. As I told you, TCA blocks histamine, TCA blocks alpha receptors, TCA blocks muscarinic receptor. So wherever you are using you don't want this interaction, you have to avoid any such combination. Like for the management of hypertension, you have to avoid and switch your class if TC is mandatory to use. Similar cases with the muscarinic agonist, and you have to switch the class, or you have to change the tricyclic antidepressant to and replace the TCS class with an alternative. And similar cases with the histamine, like CDCA blocks histamine, it causes sedative effects. So this was all about our initial introduction about the depression and its relevant mechanism of action and drug. Tomorrow in detail we will discuss again this mechanism, and with the reference to this principle we will discuss all key points which can be a part of upcoming exams. So professionals, if you feel my this effort is helpful for you, then please subscribe my channel and stay tuned. Wish you best of luck.